Hello, and thank you everyone for joining us here on this lovely Wednesday here at the end of Parkinson's Disease Awareness Month. I recognize that everyone here is probably could be at all stages of their journey with Parkinson's disease, ranging from early diagnosis to living with Parkinson's disease already for many years. So we'll try to make sure that there's something relevant for everyone in this discussion here today. So we're going to be talking about chronic pain and Parkinson's disease, which is a very important non-motor symptom. And to give you a little bit of a background on myself, I'm one of the neurosurgeons here at the JFK Neuroscience Institute. I specialize in functional neurosurgery and deep brain stimulation, which is commonly used to treat Parkinson's disease. So many of you are probably very aware of the motor symptoms that come along with Parkinson's disease, but may not be quite so aware of some of the non-motor symptoms that come along with the illness. These can range anywhere from cognitive impairment, so trouble with thinking, trouble with your judgment, some mood disturbances like depression or anxiety that can be strictly related to the Parkinson's disease itself, or even an effect of Parkinson's disease limiting your everyday activities and socialization levels, causing depressed mood. There's also some signs of autonomic dysfunction in some people, including things like gastrointestinal disturbances, which usually shows up in the form of things like constipation, orthostatic hypotension, which is a condition where when you stand up, your blood vessels don't regulate very well, leading to dizziness and a drop in blood pressure. And we've seen a lot of sleep disturbances in Parkinson's disease as well, ranging from restless leg syndrome to REM sleep disorders, meaning that there's a disturbance in the way that your sleep cycles are regulated, and even things like sleep apnea. Now, one of the non-motor symptoms we're talking about today, pain, is under sensory disorders. So that could be things like pain and paresthesias, which is like a disturbing tingling sensation, trouble with taste sensation, and trouble with smell. So here's a little bit of an overview of the state of chronic pain in Parkinson's disease. Overall, almost 3/4 of people with Parkinson's disease will suffer from chronic pain. And it's more prevalent and intense in Parkinson's disease when compared to the general population. It can even precede the appearance of your motor symptoms by several years. So sometimes I see patients that say, well, I went to my orthopedic doctor because I was having some shoulder pain or some frozen shoulder. And then a couple of years later, it turns out that they actually have Parkinson's disease. In some patients that have severe pain, that can actually overshadow the motor symptoms, and it can have a significant impact on patients' quality of life and the economy. We've estimated that the combined costs of treatment, disability, and lost income from Parkinson's disease are estimated at $52 billion annually in the United States alone. And non-motor chronic pain is a significant source of disability. There are several subtypes of pain in Parkinson's disease, ranging from musculoskeletal pain, dystonic pain, radicular pain, and central pain. All of these syndromes have a higher rate of prevalence in the Parkinson's disease population compared to the general population. For example, radicular pain has a higher prevalence in PD at up to 35% versus the general population, which can be about 10%. And the pain typically tends to affect the side with the most predominant motor symptoms. So most patients will have either one side or the other more affected by their Parkinson's disease, and that side is the side that tends to produce pain. Studies show that ultimately women and men both report pain equally. However, women seem to be more affected by the pain that they experience. And here's an example of published timelines documenting that there are some symptoms that arise in Parkinson's disease well before diagnosis and well before motor symptoms such as tremor, slowed movements, and stiffness are detected. And at that point, you've already lost quite a bit of the dopaminergic neurons in the brain that is the cause of Parkinson's disease. And if you look up in the upper left-hand corner, you can see that after things like sleep disturbance, constipation, depression, we start to see things like fatigue and pain well before the development of things like tremor and stiffness. The most common locations of pain are in the lower limbs, primarily, then in the lower back, then in the upper limbs, upper arms, and in the neck and shoulders. And there's a little bit of a difference in the distribution between the pain that women report and the pain that men report. And as of right now, we're not quite sure why this is in Parkinson's disease. Suffice it to say that we know that it's a trend, and so that we as clinicians know to look out for these types of distribution of pain. So what contributes to chronic pain in Parkinson's disease? Well, there are many different factors. One main one is that the aching, cramping, and joint pain coming from the lack of mobility produces pain. The pain does tend to fluctuate with motor symptoms, particularly stiffness and slowed or arrested movements. That stiffness and slowed movements can contribute to up to 1/3 of pain in Parkinson's disease. Interestingly enough, it doesn't so much show a trend along with tremor. And right now we're still not quite sure why this is, but we know that it is a trend. The postural changes in Parkinson's disease, such as the festination, those are those little small steps that you take to get going, and tend to increase when you're going through doorways or narrowed areas of a hallway. Kyphosis, which is a forward bend in the spine, and dystonia, which is that cramping type of pain that patients can get. Those all accelerate degeneration in the lower back, in the lumbar spine. And that frequently contributes to accelerated arthritis that can lead to pinched nerves and pain in the lower and upper extremities. Dystonia, again, that painful cramping that patients will occasionally report with Parkinson's disease, is present in up to 40% of patients. The dystonia typically occurs in the early morning when dopaminergic stimulation in the brain is low and the stiffness is more high. This usually comes about or signals itself as a focal dystonia, meaning in one place in the body, particularly with pointing the toes and inverting the foot. There's also a category of visceral pain, which is usually from constipation in Parkinson's disease, which is, again, like I mentioned before, caused by that autonomic dysfunction, that trouble with the nervous system in your gut. And this can actually also result in that dystonic contraction, that painful cramping in the anal sphincter as well. This is something that's very difficult to treat and very embarrassing for patients. There's also the pain that's directly related to Parkinson's disease, which is known as central Parkinson's pain. This can occur in up to 10% of patients. Patients usually report this as a burning, cramping, or intense tingly sensation. And it doesn't really have any association with the structural or mechanical changes that occur in the body with Parkinson's disease. And we're finding more and more that this is coming from a change in basal ganglia function, basal ganglia being one of the principal parts of the brain that's affected by Parkinson's disease. And the altered signaling can contribute to pain conditions. Here's just a general overview of the broad classifications of pain in Parkinson's disease. The most overall common type is nociceptive pain. So that's more in the sharp or aching type of pains that you get from your muscles and joints, and also that visceral pain coming from the enteric nervous system. And we see this, it can account for up to 90% of pain in Parkinson's disease. And we're estimating at least 50%. The other type of pain that's really common in Parkinson's disease is that neuropathic pain, coming from altered signaling in the brain and the neurons. Those neurons basically signal that, hey, I'm in pain, and they don't really know any better. And so then they cause you discomfort. This is an example of the hunched forward condition, which has a formal term of camptocornia, but a lot of people you might see with later stage Parkinson's disease will have this forward bend where it's hard for them to straighten up, or a kyphosis, a forward bend at the back of the neck, or similar to scoliosis, a lateral bend in the spine. And you can see those examples with those patients there and with the x-ray on the lower right-hand corner. So what are the mechanisms of chronic pain in Parkinson's disease? Well, this is something that's still undergoing investigation because Parkinson's disease has effects in a direct way and an indirect way in the brain. It's sometimes really difficult to tease those connections out and figure out what part of it is causing the problem. But we do know for certain that Parkinson's disease patients that have pain will have a decrease in the pain threshold, meaning that the level of pain required to cause discomfort is lower in Parkinson's patients. They have a decrease in pain tolerance, meaning your ability to withstand that pain over time. They also have a reduced nociceptive withdrawal reflex. And what does that mean? That means that if you feel a painful stimulus, normally you withdraw from it right away to avoid injury. And patients with Parkinson's disease have a decreased ability to do this for one reason or another. We've also found unusual activation of brain areas that are associated with pain. So over here on the right-hand side, there's a little bit of a diagram with the substantia nigra, that blue box at the center, which is one of the areas of the brain that is affected by Parkinson's disease. And it looks at all its connections to different pain centers in the brain, like the prefrontal cortex in the front of the brain, the anterior cingulate cortex, the amygdala, which is involved with kind of that visceral response to pain and unpleasant things, the thalamus, which has relay stations for pain generated in the spinal cord, so throughout the body, and then also in the face. And then it has connections to the spinal cord as well. And like I mentioned before, we do see altered signals in the basal ganglia, those parts of the brain that are affected by Parkinson's disease. But again, because there's so many different connections that are going all different ways, it's hard to really tease out which one in particular is responsible for pain in Parkinson's. And this just underscores a little bit about how complicated this system is, right? This shows the different pathways using dopamine signaling and serotonin signaling. These are both molecules and chemicals in the brain that are used to create messages between neurons. And some or all of these are connected to those center relay stations in the brain that are affected by Parkinson's disease. So what are our strategies for pain management in Parkinson's disease right now? Well, the first step is recognizing that quality of life requires pain management. It requires your primary care doctor or your neurologist to pick up on the fact that you're having pain that's unusual, or pain that's in one of those tiers of pain generation, like the nociceptive or the neuropathic pain or the central pain that comes with Parkinson's disease. Then we can actually start managing it. One of the things that we frequently ask patients to do is keep a pain diary to document and describe your pain over time, because depending on where your pain is, the management is different. It is pretty complicated. Along with medication management with traditional pain medication, and then also dopamine containing medication that's typically used in Parkinson's disease, we try to get patients locked into a physical therapy regimen early on, since we know that increasing activity levels and preserving those activity levels helps prevent progression of Parkinson's disease over time. And then after physical therapy, exercise, medications, some injectable things that we'll go over in a little bit, there are things like surgical management of pain. So first of all, pain diaries. There's a couple different diaries that are recommended by the Movement Disorders, the MDS Task Force on rating scales. One of those is the Parkinson's Disease Home Diary and the CAPSIT PD diary. Now, these diaries have known limitations. They don't do very well at describing non-motor fluctuations. So fluctuations in your mood, fluctuations in your pain, fluctuations in your heart rate and blood pressure. It also doesn't really recognize partial states. So let's say that you have 50% of your tremor or 50% of your stiffness at the time. It's not really well categorized and well documented in these diaries. That's also goes along with incomplete definitions of on and off states. For those that aren't familiar, on and off states refers to your effect of dopamine medication. So when you're on, that means that you have an effect and you are noticing an effect from the dopamine medication. And when you're off, like at the end of your dose and right before your next dose, you are feeling the full extent of your Parkinson's disease symptoms, and you're not really feeling that medication as much. These are also, quite frankly, underutilized. Not a lot of patients know about them. This is becoming more widespread in the clinical community. We're picking up on the fact that it's important to know what patients are like when they're at home and they're not in the office, because the hours that you spend in the office being evaluated by a doctor or a therapist, it doesn't even come close to the amount of hours you spend at home with your loved ones, with your caregivers. So this is really important information that we should be paying attention to. One of the things that's coming up in the future, and even now, some of you might have these sorts of things, are wearables. So like the Apple Watch that has an accelerometer in it, so it can measure your tremor, or different ways of measuring stiffness. Even in the future, we're looking at devices that can measure your concentration of dopamine in your system, much like a glucometer. So these things coming up will all be very important going forward. So medication management, this is probably what gets a lot of attention in the office. So dopaminergic medications, that's your Sinemet, your Rytary, all of those medications that contain levodopa, which are mainstays of treatment in Parkinson's disease. Those can actually help with management of pain. Like I mentioned before, we do see fluctuation of pain along with fluctuation in things like stiffness or slowed movements. The dopaminergic medication smooths out those fluctuations. Ipso facto, it helps smooth out the pain. And we've seen this be effective for all of those types of pain, the musculoskeletal, the dystonic, that cramping, the akathisia, which is things like restless legs, and central pain from Parkinson's disease. However, there are a lot of patients that don't report a lot of difference in pain between their on medication and off medication states. We principally see this in patients that are later in their Parkinson's disease treatment. Things like supplements, these are easy things like calcium and vitamin D can be very helpful in the management of musculoskeletal pain. That doubles as a treatment for osteopenia and osteoporosis, brittle bones that come as a result of aging. Patients with Parkinson's disease are more likely to have those sorts of conditions where their bone density isn't as strong, their bones aren't as strong, because especially in later years, Preservation of bone density has a lot to do with exercise and strength training. And a lot of patients with Parkinson's disease, they have limited ability to keep up with those sorts of things. So calcium and vitamin D, very important. Another supplement that can be very helpful is B12. It's a B vitamin that is primarily helpful in the treatment of neuropathic pain. So that pain that shoots down into your arms or your legs, it can be burning, it can be shock-like, electrical. I've had people say it's like a cattle prodder. I don't know how many people know what cattle prod is or does, but it's a very interesting example. But B12 can be helpful. Iron. Iron can be helpful as a supplement for restless leg syndrome, which is a significant source of discomfort in Parkinson's patients, and it can disrupt your sleep. Antidepressants. Antidepressants can help with pain management in Parkinson's disease. Primarily the serotonin and norepinephrine reuptake inhibitors. Those are two different chemicals that help communicate between neurons in the brain. You can also see it abbreviated as SNRI, or tricyclic antidepressants. You can see that abbreviated as TCAs. An example of the SNRIs are venlafaxine, known as Effexor, or duloxetine, which is known as Cymbalta. And the tricyclic antidepressants are things like amitriptyline, Elavil. I've had a lot of success in using this for patients, and then nortriptyline or Pamelor. Now, there's probably a direct effect of these medications on pain due to changes in that signaling between those molecules that are affected by the medication. There's also probably an affective component as well that's indirect in improvement of pain. That is to say that when a patient's depression or anxiety improves, they tend to have an improved perception in their level of pain. So this is very helpful for things like that central pain that we mentioned being a problem in up to 10% of Parkinson's disease patients, and that neuropathic pain. There's even more medications that we can discuss with respect to management of pain in Parkinson's disease. The COMT or COMT inhibitors, such as entacapone, is the most common one that I see used. They all have this in common that they end in capone. So the tolcapone and the opicapone, those are a little bit newer. Those are all COMT inhibitors. So those will prevent wearing off changes in your dopamine containing medications like Sinemet. And they can also be independently helpful for things like neuropathic pain. The rotigotine patch, which is called Nupro. I know a lot of you are familiar with this as well. This can be very helpful for central Parkinson's disease pain and restless leg syndrome. It actually activates dopamine receptors in both the GI tract and in the central nervous system, and that's how it helps control pain. Non-steroidal anti-inflammatories, NSAIDs. This is just two things. There's many NSAIDs out there, but some of the most common ones are things like ibuprofen or diclofenac. And those are oral medications. You can also use topical NSAIDs, which are applied to the skin, so things like Voltaren gel. Now, I know some of you might have seen that there was some early evidence many years ago that implicated excessive NSAID use in the development of Parkinson's disease, but that's now been shown to be disproven in the most recent data in the medical community. These medications are very useful for musculoskeletal type pain, those aches and pains in your joints and muscles. Gabapentin, which is also called Neurontin. This is a very commonly used medication for neuropathic pain in all sorts of conditions. So it makes sense that it can be helpful in Parkinson's disease. And there is actually also some data that suggests that it can improve all cardinal motor symptoms of Parkinson's disease. So things like the stiffness, the rigidity, the slowed movements, the tremor. These can all improve with gabapentin as well. I think the reason why this doesn't get used as much in patients with Parkinson's disease is because overall, they tend to be on the older side, and it can have some significant side effects like sleepiness or brain fog that make it difficult to get through the activities of daily life. Opioids, of course, we all know about opioids. These are, farther down on the list in terms of management for Parkinson's disease related pain. These are your things like oxycodone, morphine, tramadol, and codeine. And then cannabinoids, this is an emerging area of research. The cannabinoid system, which everyone has in them, in the basal ganglia, has a strong influence on the progression of Parkinson's disease. So we've seen in studies that both motor and non-motor symptoms are responsive to cannabinoids such as cannabis or CBD or THC. In the particular study that was the most recent, stiffness, tremor, freezing of gait, depression, anxiety, and restless leg syndrome improved for 20% of people. It had good tolerability and overall improvement in things like pain and muscle cramps was up to 54% in patients that were using CBD, either orally or spread on the skin, and up to 68% of patients that were using THC. But more data forthcoming in the future. So this is a little bit of a summary of a lot of those medical treatments that I just went over for Parkinson's disease. Based on what kind of pain you have, the musculoskeletal, the neuropathic, the dystonic, the acanthitic, that's the restless leg syndrome, or the central pain, there's different strategies for managing those types of pain. One of the things that's mentioned on that previous slide, I can just show it real briefly back here, are things like botulinum toxin or Botox injections, and then epidural or joint steroid injections. So Botox injections are frequently used for dystonic pain. So that's the painful cramping in the, mostly I see it in the toes and the feet, especially in the morning. Sometimes I have patients reporting it in their fingers as well. So Botox is something that can be very helpful for this sort of pain if you don't respond very well to medications. The Botox injections are done by our neurologists in the office. So there is just a minimal amount of time that it takes to do this injection. The Botox can also be used for things like trouble with bladder function in Parkinson's disease, drooling, also known officially as sialorrhea, but drooling, tremor, and the restless leg syndrome. Epidural or joint injections are typically done with a mixture of steroids and a little bit of one of those non-steroidal anti-inflammatories. It varies across different practitioners and different areas of the United States. There's on the right side a little bit of an illustration of what exactly happens in an epidural injection. There's a needle attached to a syringe that under X-ray guidance is guided to the epidural space. That's the space that is on top of the covering of the spinal cord and nerves. And then we put that steroid anti-inflammatory cocktail right over that nerve where the pain is coming from to hopefully calm things down quite a bit. Same thing can be done, and you might have had done for joints such as the knees or the shoulders, and that can help provide some immediate relief in pain. It doesn't typically last Everyone is a little bit different. It can last anywhere from a few days to a few months. And it's something that we try not to perform more than 2 or 3 times because there can be some changes that occur in those joints as a result of the steroid or anti-inflammatory being there. These injections are done by pain management physicians, and again, typically done under X-ray guidance just to make sure the needle is going into the exact right place. Exercise. This is a big one in the Parkinson's disease community. As I mentioned before, increasing physical activity to at least 2.5 hours per week can slow Parkinson's disease progression. And this doesn't have to be you going completely out of breath in the gym for 2.5 hours a week. That includes all of these things like aerobic activities, so walking, biking, hiking. Some people like to get out on the water and do a little canoeing or kayaking. Strength training, targeting those major muscle groups, especially squats. Squats have been shown to be one of the few exercises that can help prevent falls as we get older, because you're strengthening all those hip muscles that help you get out of chairs or stabilize yourself from a near fall. Physical activities such as balance, agility training, things like yoga or Pilates or Tai Chi, not an exhaustive list. These are also really important for Parkinson's disease patients to strengthen their balance sense. And like any muscle, you have to work it out to see improvement and delay any worsening as part of the Parkinson's disease. And of course, stretching. Stretching is really important for maintaining mobility in all of your joints, muscles, and tendons. Of course, you don't want to overdo it, but improving the mobility of those muscles is going to help with your symptoms like stiffness or rigidity. And like I might have mentioned earlier on, we try to refer patients early for physical and occupational therapy. This is to, we recognize that not everyone has experience with going to the gym. Not everyone has experience with balance training or stretching or strength training. So the physical therapists are there to help guide you and provide you education and self-management advice so that you can do exercises at home after you practice them with a therapist. Like I said, they guide those exercise routines, so getting you the best bang for your buck. So making sure that the time that you're putting into these activities is helpful time and not hurtful time. They help you maintain safety while you're doing these exercises, especially because patients with Parkinson's disease have a lot of instability in their posture and their walking. So we want to make sure that you don't experience a setback with doing these exercise routines. And they help you with that fear of falling. So it's helpful to have someone there that is prepared to grab onto you if you're about to fall as you're practicing these exercises. And at home, you can do this by standing close to a wall or close to a heavy piece of furniture that's not going to move on you when you grab it, just to help with that fear of falling. There's a lot of resources out there for guiding exercise programs in addition to your physical and occupational therapists. The American Parkinson's Disease Association has a whole guide called Be Active and Beyond that is specifically tailored for patients with Parkinson's disease at all stages of illness. And then I know a lot of people really enjoy taking advantage of group activities such as rock steady boxing, and I know there's others out there. Number one, because it keeps them dedicated, it keeps you accountable for continuing these exercises. And a lot of people like the social aspect of it as well, especially because a lot of patients might feel more withdrawn or might be reluctant to go out and interact socially as a result of their illness. Lastly, surgical treatment can be really effective for Parkinson's disease. Now, this is more in my area since I do functional neurosurgery, I do deep brain stimulation. And I actually co-authored a paper at the end of last December looking at data across all previous published papers with respect to pain improvement in patients that underwent deep brain stimulation for Parkinson's disease. So it has been very well shown to have an effect on chronic pain in PD, despite being traditionally known for motor symptom improvement. So what is deep brain stimulation if you haven't heard about it? It's a surgically implanted device that sends electrical signals to the brain to control motor symptoms. It consists of 2 leads that go into one of those deep relay stations in the brain called the basal ganglia, an extension lead which connects the brain lead to a battery, which is placed underneath the skin of the chest. All of this is underneath the skin, so you don't see any of it. And a lot of people liken it to a brain pacemaker is the best used analogy for patients that have pacemakers with different kinds of cardiac conditions or heart conditions. So what do we know? What does the data show? Recent studies suggest a 79% improvement in chronic pain with subthalamic nucleus stimulation. That's one of the 2 targets we commonly use for Parkinson's disease, one of the common places we put those electrodes, and a 75% improvement with palatal stimulation and the globus pallidus interna. That's the 2nd target that we use for Parkinson's disease. Now, which target we use for which person depends a lot on what kind of Parkinson's disease you have and what are your most bothersome symptoms. And we don't typically do deep brain stimulation early in a patient's course. We tend to do it when we get to the point where medications really aren't giving you that benefit during the day anymore. A lot of patients will be really responsive to dopamine and Sinemet, Rytary, those sorts of things early on in their treatment, but then over time they can lose efficacy, and eventually patients will take the medication and they don't feel much at all, or they might just feel side effects from the medication, and that position is not really doing you much good. So then we look to other solutions like surgery. And the effect on chronic pain in patients with DBS works for both the perception of your pain, so your overall feeling towards your pain and how troublesome it is in your daily life, how limiting it is, and then also in the level of the pain. So when people ask you on a scale of 0 to 10, where is your pain? That's the level of pain that I'm talking about is decreased with deep brain stimulation. And this is an old diagram comparing and contrasting the changes in symptoms of Parkinson's disease patients that undergo deep brain stimulation. So over on the left side, those big blue bars, those are your dyskinesias, those uncontrollable big movements that can be both a result of medication and a wearing off of medication. Improvement in motor fluctuation, improvement in tremor and stiffness and slow movements. And then over towards the right, we start getting into those non-motor symptoms, such as the depression, the sleep disturbances and pain. And now even this was from 2018, so this was 5 years ago. So we know a lot more now about non-motor Parkinson's disease compared to what we knew then. And we're seeing that the effects of deep brain stimulation are actually very helpful for these things that we thought weren't as responsive. So in conclusion, chronic pain in Parkinson's disease is widespread, and it requires special considerations and treatment due to the many types of pain in Parkinson's disease and altered pain signaling in the brain as a result of Parkinson's disease. PD pain can surface well before the appearance of motor symptoms and diagnosis, frequently proceeding by several years. Pain management in Parkinson's disease is very complicated, and it's best managed by a multidisciplinary team consisting of neurologists, interventional pain management physicians, physical medicine and rehabilitation physicians, physical therapists, and occupational therapists. And finally, surgical treatment of Parkinson's disease with deep brain stimulation can be effective against chronic pain, in addition to improving those motor symptoms. So again, happy Parkinson's Disease Awareness Month. I hope you've all enjoyed the different programs we've had put on throughout the month, and we'll continue to support you as clinicians and a multidisciplinary team as best we can. This was part of my team at the moving day back in October. So myself, a couple of neurologists, and one of our nurses. And if you would like more information, these are a few of my team here at JFK. Dr. Hanna, Dr. Svetlanov, and newly Dr. Peruli are here at the JFK Neuroscience Institute in Movement Disorders Neurology. Dr. Ronald Karnov is one of our interventional pain physicians. And of course, there's myself in the neurosurgery column, along with Dr. Bloomfield. And then we have a fantastic resource at the JFK Johnson Rehabilitation Institute with Dr. Shostorovich, Dr. Van Deen, and Dr. Delaveau, all in that physical medicine rehabilitation. And they also do a lot of pain treatment as well. So thank you very much for joining us today. I hope this was very helpful, and we'll open it up for any questions.